It's a pleasure to be here today by recording to present a lecture to you on eosinophilic esophagitis, and the title is Eosinophilic Esophagitis, Don't Miss It. These are my disclosures. None of them will impact what I'm going to tell you today. And these are our session objectives. We'll describe the symptoms, clinical presentation, endoscopic and pathologic findings associated with eosinophilic esophagitis. I'll outline a practical approach to the evaluation of patients with suspected eosinophilic esophagitis, and we'll review the treatment options for managing eosinophilic esophagitis, or EoE. Let's start with the case. Tommy's a 3-year-old boy with eczema, egg allergy, peanut allergy, and asthma who isn't growing well. He's a selective eater, a term we use rather than picky because picky is somewhat judgmental. He's a slow eater with a poor appetite and a self-restricted diet. He drinks lots of liquids with his meals. He usually takes a bite and then takes a swallow of liquid. He won't try new foods. He'd rather drink than eat and won't even attempt to eat meats or breads. He occasionally chokes, gags, and vomits while eating. And he sees a gastroenterologist and has an endoscopy that reveals eosinophilic esophageal inflammation. Other causes of esophageal eosinophilia are ruled out, and he's diagnosed with eosinophilic esophagitis. So the eosinophil is an incredibly potent cell and a very important cell both in health and disease. It's got a large number of receptors on its surface that help it react to different signals in the environment. And as I mentioned, it's very important in health and disease. It's got a number of different very potent mediators that can help calm down an inflammatory response or actually drive the inflammatory response. And it's got a number of different functions within the intestinal mucosa. It can impact epithelial cells and disrupt the epithelial barrier. It can impact goblet cells, leading to increased mucus secretion. It affects fibroblasts and can lead to proliferation and remodeling with fibrosis. It can impact endothelial cells, leading to cytokine production and angiogenesis. It can affect neurons, leading to neuropeptide release, and smooth muscle cells, leading to proliferation and contraction, as well as remodeling. It impacts mast cells and eosinophils. So it's a very important cell with lots of different roles in the intestinal tract. As a result, it's normally found throughout the GI tract except for in the esophagus. Numbers increase from the fundus of the stomach to the cecum and decrease from the cecum to the rectum. So, what's a brief definition of eosinophilic esophagitis? Well, it's a clinical pathologic disease, which means there are symptoms related to esophageal dysfunction like difficulty swallowing. In addition, it's a pathologic disease, so that means that one or more esophageal biopsies show eosinophil predominant inflammation, meaning there's more than 15 eosinophils per high power field. So the diagnostic algorithm is as follows. A patient presents with symptoms suggestive of esophageal dysfunction. They have an endoscopy with biopsies. The biopsies reveal more than 15 eosinophils per high power field, or about 60 eosinophils per millimeter squared or more. Other causes of esophageal eosinophilia are ruled out, and the diagnosis of eosinophilic esophagitis is made. Now, there are a number of other entities that can cause esophageal eosinophilia, but eosinophilic esophagitis is one of the most common. But we also see hypereosinophilic syndrome, celiac disease, Crohn's disease, or connective tissue disorders that can present like this, as well as gastroesophageal reflux disease, which is another one of the most common ones. So EoE can affect all ages, all ethnicities, and has been found on all continents. In the United States, the prevalence is about 1 in 2,000. There's a male-to-female ratio of 3 to 1, meaning about 75% of the patients we see are males. You can see familial cases in about 7 to 10% of the cases we see. The brothers' relative risk ratio is about 64-fold higher than the normal population. And there is a concordance between monozygotic twins. For example, if one monozygotic twin has it 58% of the time, the other one will have it. In dizygotic twins, it's about 36% of the time. And in non-twin siblings, it's about 2.4%. So this tells us that something goes on that's very important in utero and in the early years of life in the environment, because that's what the twins would have in common, in addition to genetic factors. Now, these are the risk factors for the development of eosinophilic esophagitis, and there's a genetic susceptibility and epigenetic modifications, and some of these likely occur in utero because of what we just talked about in regard to monozygotic and dizygotic twins. A number of the things in infancy that impact this are things that would impact the microbiome. So cesarean delivery, NICU admission, antibiotic use of acid suppressants, formula feeding rather than breastfeeding, and the absence of exposure to furred pets, because we share microbiomes with furry pets that we have in the home. And then later in life, there are other things that play a role, like season and climate, whether you smoke or vape or have other infections. And a number of these patients with eosinophilic esophagitis have comorbid allergic disease. In fact, the majority do. They either have food allergy or allergic rhinitis or asthma or atopic dermatitis. Their total serum IgE level is elevated, and 40 to 50% have mild to moderate peripheral eosinophilia. So what are the symptoms suggestive of eosinophilic esophagitis? Well, they vary depending upon age. Early on, we see food aversion or food intolerance and failure to thrive, sometimes associated with vomiting. As children get older, they can tell you about epigastric or chest pain. We also can learn about dysphagia from children, although you see it more in adolescents and adults. And food impaction also is a form of presentation of these patients when they have significant dysphagia, esophageal stricture, and food impaction. The complications, therefore, are feeding dysfunction, malnutrition, and failure to thrive, esophageal stricture, which can result in food or foreign body impaction in the esophagus. Thank goodness cancer is not a complication. But these patients are often missed until they present with significant dysphagia, and that's because they have coping mechanisms. They compensate. They eat their food slower than everybody else. They like to take a small bite, put sauces on it, chew it for a long time, and then take a drink of liquid to swallow it down. Sometimes if food gets stuck, they have to leave the table to get it out. Some of them avoid eating in public. Some of them won't even try to eat dense or textured foods. And there's some small children who will chew up the food, leave it in their cheek, and walk around for a while, and then either spit the food out or slowly swallow small amounts over time. So these are the questions to ask to get a good history that will make you think about whether a patient has eosinophilic esophagitis. And one of the first questions to ask is your child a slow eater or a selective eater? I mean, are there foods they won't eat? When you look at the esophagus using an endoscope, this is what you see in patients with eosinophilic esophagitis. You can see furrows, which are those lines headed down the esophagus seen in panel A. You can also see the exudates in the panels on the right, and you can see the rings listed, the circular rings in panel A on the bottom on the left. In panel A here, you see a normal esophagus. You can appreciate the vascularity. There isn't any edema, so you can see it well. In panel B, you see a white exudate. In panel C, you can appreciate rings. In panel D, you can see the furrows. And in panel E, there's a stricture. Panel F shows you a longitudinal tear. These patients are said to have a crepe paper mucosa that is easy to cause a rent when you're doing your endoscopy. Or if you're going to dilate the patient, you can see these rents afterwards or tears afterwards. Now, endoscopists use a scoring system called EREFS, which stands for edema, rings, exudates, furrows, and stricture, and that's what I just showed you in those previous slides. They grade those, each one, and come up with a final score that the higher the score, the more severe the symptoms, or the severe the findings. Now you have to remember that biopsies take only a small sample. It's about only 0.01% of the surface area of the esophagus, so you need to take a couple of samples distally, a couple in the mid-esophagus, and a couple proximally, or you might miss it. When you look at it under a microscope, you see more than just increased eosinophil number. Although you will see increased eosinophil number, you can see superficial layering of eosinophils on the top of the epithelium. You can see eosinophil abscesses as seen in the bottom picture on the left, frame B. You can see basal zone hyperplasia, dilated intercellular spaces, and lamina propria fibrosis. And in this slide, you can see that the bracket shows you papillary elongation. The circle shows you basal zone hyperplasia. The thin arrows show you eosinophils, and the thicker arrow shows you dilated intercellular spaces. And this is an example of subepithelial fibrosis that can be seen on biopsy in panel B. You can see this is a patient after 10 years of eosinophilic esophagitis that wasn't appropriately treated. So what are the triggers of eosinophilic esophagitis? The most common are food antigens. Airborne pollens can also play a role in some patients and lend seasonality or seasonal worsening to the disease. And then there are other allergens such as dust mite, etc., that might play a role in some patients. Which are the most common foods? The most common is milk and dairy products, followed by egg and wheat in another quarter of the patients. But it may also depend on where you live and your age. In the United States, milk, egg, and wheat are the most common. In children and adults, it's milk and wheat. In Spain, it's soy and legumes are more common than they are in the U.S. Interestingly, one food is the driver for about a third to a half of the patients. In about 30% of the patients, 2 foods are the driver, and in about 10%, it's 3 or more foods. So what about allergy tests for eosinophilic esophagitis? Well, skin testing, unfortunately, although it's very helpful for IgE-mediated disease, is not particularly helpful in eosinophilic esophagitis because EoE is not an IgE-mediated disease. So the skin tests and serum IgE tests aren't reliable for identifying foods causing eosinophilic esophagitis. So is there a role for allergy tests in EoE? Yes, there is, because some of these patients have IgE-mediated food allergy. In some of the cases, empiric elimination diets aren't working, and we're trying to find any information we can about sensitization to a food, so we might use skin testing in that setting. We like to skin test patients before the removal of a common food allergen like milk or egg or wheat, because if they're sensitized and you remove the food, they might have symptoms on reintroduction. So sometimes we also skin test a patient before reintroduction of a common food that's been taken out of the diet, so we can decide where the food needs to be reintroduced. Can it be given at home or should it be given under medical observation? Then environmental allergen testing can be helpful if the patient has allergic rhinitis or asthma or eczema, or we're worried about animal dander allergy. So unfortunately, there is no perfect predictive lab test for identifying EoE triggers. I've already talked to you about skin testing to foods and aeroallergens. Immunicaps are no better. IgG4 levels are not there yet, but we might be able to use them in the future. Patch testing and lymphocyte stimulation have not been successful either in identifying the triggers. So what's the algorithm for diagnosis and management of eosinophilic esophagitis? Well, we take the history. We look for a family history of allergic disease or history of severe GERD or strictures or dysphagia or eosinophilic esophagitis, and a personal history of allergic disease in the patient, and then they complain of difficulty feeding, vomiting, failure to thrive, epigastric or chest pain, dysphagia, and food impaction. At that point, we might want to obtain an esophagram to see if they have evidence of a stricture, because if they do, we might want to dilate them on their first endoscopy. Then we obtain an endoscopy with biopsies and see if they have more than 15 eosinophils per high power field. If they do, we rule out the other causes of esophageal eosinophilia, but if the findings are inconsistent with eosinophilic esophagitis, then we treat them for GERD or other diseases and monitor the clinical course. However, if they do have findings consistent with eosinophilic esophagitis, then we consider one of the 3 Ds: diet, drugs, or dilation. The most common first used drug is a proton pump inhibitor. It works in about 30 to 50% of patients, and they're given 20 to 40 milligrams of a selected PPI twice daily, depending upon age and size. And the potential benefits of long-term use are symptom improvement. There are anti-inflammatory properties of PPIs. It's more than just inhibiting acid secretion. It promotes healing of the esophageal mucosa and actually has been shown to reverse the gene expression associated with allergic inflammation. So these can be very helpful in some patients. In those who don't respond, we generally look next to swallowed topical steroids. And again, the swallowed topical steroids are given by having them use an asthma inhaler and squirting it in the back of their throat and swallowing it and not breathing in while they do that, and then not eating or drinking or brushing their teeth for 30 minutes afterwards. Or we use budesonide, which are respules, so it's a liquid. We mix it with Splenda or some other vehicle such as applesauce. And again, the dose is dependent upon age. They take it twice daily. They don't eat or drink for 30 minutes after. And then we follow up usually with an endoscopy in a couple of months to see if they've responded to current treatment. Now, some patients would rather not use medications, so we use diets. Elemental diet is the most effective. That means that the formula is broken down to its smallest parts so that they're only amino acids or simple sugars, and it can't stimulate the immune system. The problem is that's not very practical. Older patients can't drink enough of this to meet their nutritional requirements, and it's socially isolating as well as expensive. So we save that for young children and patients who aren't responding to anything else, or those who really want to know if food is playing a role in triggering their diet and have failed other diets, triggering their EoE and have failed other diets. Then there's the empiric elimination diet, which is one of the most common dietary options used, and that's where you remove the top food allergens. There's the 2 food where milk and wheat are avoided, the 4 food where milk, wheat, and soy and egg are avoided, the 6 food where you avoid milk, egg, wheat, soy, peanuts, tree nuts, fish, and shellfish, and the 6 food is effective in about 70% of patients. About 60% or so respond to the 4 food, and about 40% to the 2 food, with about 30% to milk alone elimination. Then there are target-directed elimination diets that are based on skin and patch testing. Unfortunately, these are not more effective than the empiric elimination diets, but they can work in anywhere from 40 to 70% of the patients. So some people are doing skin testing to help them decide on foods. There are a number of considerations when you put someone on an elimination diet. You need to understand their current nutritional status. You don't want to take away the major foods for someone who's failing to thrive and can't get adequate nutrition otherwise. You have to check for patient ability and willingness. For example, I have a number of young children who just can't do it. They can't avoid it. When they go to school, they'll eat the food because they're just not ready to try an elimination diet. Some of these kids also have feeding issues because some children develop EoE in the first few years of life when they're learning how to eat properly, and they actually have to have feeding therapy in order to help them learn how to eat appropriately. Then they have to have the social support, parents who will help them stay on the diet, and the financial resources, because sometimes the foods are a little more expensive. It depends on the patient lifestyle. I have patients going to college that feel like an elimination diet is just too much, so they want to use swallowed topical steroids instead. There's some patients who their quality of life suffers if they can't eat certain foods, so they'd rather try medications. And then it's always helpful to have a registered dietitian involved in examining the nutritional adequacy of the diet of these patients and also helping them make a transition to an elimination diet if that's the route they decide to go. It's just almost impossible to do without a registered dietitian or someone who really is versed in nutritional issues and knows how to find foods that taste like other foods but have different ingredients, for example. Then there's esophageal dilation, where you dilate the esophagus using a balloon. This is not recommended as monotherapy because eosinophilic esophagitis is an inflammatory disease, and the symptoms return if you don't treat them with an anti-inflammatory agent or a diet. Risk of rupture is small. We tend to reserve esophageal dilation for patients who have not responded to other therapies or are not making progress. And again, once they're dilated, that'll last for a year to 2 years. But again, they'll last longer if you use anti-inflammatory medications, not to be used as monotherapy. There are less invasive tests which are coming out. We have an unsedated transnasal endoscopy where they numb up the nose and then slip the endoscopy down the nose and take biopsies of the esophagus and look at the stomach. They can't see anything beyond the stomach, but that can be helpful. It's a 5-minute procedure, doesn't require sedation. There are other methods where the string, which is attached to a capsule, you take the string, pull a little bit out, tape it to the cheek, have the patient swallow the capsule. The string unwinds from the capsule drops off in the stomach. You leave it down for an hour, then pull the string out, mark it where it was in the esophagus, clip it and send it off to measure eosinophil mediators on the string that correlate with the number of eosinophil mediators in the esophagus. The cytosponge is a similar approach, but there's a sponge on the bottom, and when you pull it up, the sponge collects debris along the esophagus. That's then collected and spun down and examined for eosinophils. Now, the initial management is to educate patients about eosinophilic esophagitis, what causes it, and the fact that it's a chronic disease. It's not something we're going to cure immediately and then it's not going to be a problem. It tends to be a chronic disease. So you have to discuss how different therapies work, the benefits and the problems, the pros and the cons, and make sure they understand that they can switch from one to the other if it's not working or they're not happy with their initial approach. We have some patients who start out with medication with the idea of moving to a diet later. We also review how elimination diets work, how to maintain that diet and avoid the foods that are eliminated successfully. If they decide on medications, we teach them how to take the medications correctly and the potential side effects, although they're usually relatively well tolerated. It's rare to have adrenal suppression from these doses of swallowed topical steroids. And then we optimally treat other allergic disease. Long-term management is checking in with them frequently to make sure they're responding to treatment and they're staying on treatment. Are they improved and ready to add a food to their diet? Can we reduce their dose of medication if their recent endoscopy with biopsies is normal now? We need to find out if feeding is affected. Do they need feeding therapy? Is their feeding affected because they have eosinophilic esophagitis or because they don't like the diet? You have to review the current diet they're eating and follow up on their nutrition and growth. Are they growing well? You have to understand or find out how often they're exposed to the eliminated foods. Are they doing it occasionally or just on birthdays or more frequently than that? Have they developed allergy to a food that's been eliminated from their diet? You took milk out of their diet, and now when they accidentally eat it, they get allergic symptoms, nausea, vomiting, hives, difficulty breathing. Have they developed other allergic disease, asthma or allergic rhinitis? And what is the impact of eosinophilic esophagitis on their quality of life? So we've just taken a minute to review how to identify patients with eosinophilic esophagitis, how to make the diagnosis, what their presenting symptoms are, how to manage them, and then how to follow them up. And I hope this has been helpful. I really appreciate your attention. Thank you very much.